Hello everyone, hope you all are having a nice day. Today we are going to learn about the topic chronic kidney disease. So let's start with the definition. Chronic kidney disease is a progressive, irreversible decline in the kidney function or any structural abnormality with reduced GFR, glomerular filtration rate (eGFR) of less than 60 ml per minute per 1.73 meter square or albuminuria of greater than 30 mg per day, lasting for at least 3 or more months. Now let's move on to the etiology. First point, diabetic nephropathy. It is the most common cause. Second, hypertension. Second most common cause. Third, glomerulonephritis. Fourth, polycystic kidney disease. Genetic disorder causing cyst formation. Fifth, obstructive nephropathy due to kidney stones, BPH, tumors. Sixth, drugs and toxins, NSAIDs, aminoglycosides, and contrast agents. Seventh, autoimmune diseases like SLE, systemic lupus erythematosus, and vasculitis. Now let's move on to the pathophysiology. Nephron loss leads to remaining nephrons undergoing hyperfiltration, leading to increased glomerular pressure, leading to progressive damage. Second, proteinuria and inflammation accelerate the fibrosis. Third, RAS activation worsens hypertension and nephron loss. Staging of CKD based on the KDIGO criteria based on eGFR. Stages. Stage 1. eGFR of greater than equal to 90. Description: there is evidence of kidney damage with normal GFR. Example: proteinuria, hematuria, structural abnormality in USG. Stage 2. eGFR 60 to 89. There is mild reduction in GFR. Stage 3A. eGFR 45 to 59. Description: mild to moderate decrease. Stage 3B. eGFR 30 to 44. Description: moderate to severe decrease. Stage 4. eGFR 15 to 29. There is severe reduction. Stage 5. eGFR of less than 15 or dialysis, kidney failure, ESRD, end stage renal disease. Let's move on to the albuminuria classification. Category A1. Albumin to creatinine ratio is less than 30 mg per g. Description: normal or mild. Category A2. Albumin to creatinine ratio 30 to 300. Description: moderate, microalbuminuria. Category A3. Albumin to creatinine ratio greater than 300. Description: severe macroalbuminuria. Clinical features. First, early stages. There is nocturia, frequent urination at night, and polyuria. All this due to decreased concentrating ability of kidney. In later stages and advanced CKD, there is volume overload, leading to peripheral edema and hypertension. There is electrolyte imbalance, leading to hyperkalemia, hyperphosphatemia, hypocalcemia, and metabolic acidosis. HCO3 decrease. Third, uremia. There is nausea, vomiting, pruritus, metallic taste in mouth, and confusion. Fourth, anemia. Normocytic, normochromic anemia due to erythropoietin deficiency. Fifth, renal osteodystrophy. There can be bone pain and fractures. Sixth, neuropathy. There are restless legs, paraesthesia, muscle twitching. Seventh, flank pain. Kidney stones, polycystic kidney disease, and hypernephrosis. Investigations. Blood investigations. Renal function test. A. Serum creatinine increased. B. Estimated glomerular filtration rate, most important marker for CKD staging. C. Blood urea nitrogen gets elevated. BUN to creatinine ratio helps differentiate pre-renal cause from intrarenal causes. Pre-renal cause, the ratio is increased. Intrarenal cause, the ratio is normal. Serum electrolytes. Hyperkalemia due to impaired potassium excretion. Hyponatremia due to water retention. Too much water dilutes the sodium concentration in the blood. Then there is metabolic acidosis, decreased HCO3, decreased pH due to impaired acid excretion. serum calcium, phosphate and parathyroid hormone. There is hypocalcemia, hypophosphatemia and elevated PTH. Serum albumin is low in CKD. Now urine investigations. Urine analysis. Albumin to creatinine ratio of less than 30 mg per g is normal. 30 to 300 mg per g microalbuminuria, early CKD marker, and greater than 300 mg per g macroalbuminuria, advanced kidney damage. Second, hematuria, RBC in urine, suggests glomerulonephritis or nephritic syndrome. C. CAS, granular waxy RBC CAS, indicate tubular damage. WBCs and bacteria suggest urinary tract infection. Now, the third point, imaging studies, renal ultrasound. If there are small sunken kidneys, there is CKD. If there are enlarged kidneys, there is polycystic kidney disease, diabetic neuropathy, and amyloidosis. Hydronephrosis suggests obstruction, example stones, prostate enlargement. CT scan or MRI detects tumors, cysts, or vascular abnormalities. Renal Doppler evaluates renal blood flow, useful in renal artery stenosis. And renal biopsy indicates if there is a cause of CKD is unclear. Management. Lifestyle and dietary modifications. First, salt restriction of less than 2 gram per day for BP control. Protein restriction of 0.8 gram per day per kg per day. Protein restriction of 0.8 gram per kg per day in advanced CKD. Potassium restriction. Avoid potatoes, coconut water, milk, yogurt. Fourth, phosphate restriction. Dairy products and soft drinks must be avoided. Fifth, smoking cessation and exercise to reduce cardiovascular risk. Second, blood pressure control. Target BP of less than 130 by 80 mmHg. ACE inhibitors, first line treatment in proteinuric CKD. Diuretics, thiazides for mild CKD and loop diuretics for advanced CKD. Glycemic control, diabetic CKD. So target HbA1c of 6.5 to 7%. SGLT2 inhibitors like empagliflozin and dapagliflozin slows the CKD progression. Thank you. Have a nice day. Keep supporting.